So thank you ever so much to the organizers for the opportunity to tell you a little bit more about the work that we have been doing and researching over the last few years, and of course, the work that's to come, and I think it's really exciting. So of course, I'm Enrique Castro. I work at Imperial College London, and I'm very grateful to them as well for the opportunity to be here. So, of course, again, I'm happy that I haven't got this slot after lunch as usual, so I've got this slot before lunch. And I think that Neil and the organizers were thinking, okay, you know, science has gone out of the window, the nurses are going to be talking about nurses' roles and so on. But I think I would like to present you a slightly different perspective about what I think that nurses could be doing. Of course, my conflict of interest, or my disclosure of interests are there. I've been funded to study how well nurses can perform in terms of participating in antimicrobial stewardship programs. And of course, this presentation doesn't at all represent the view of any of my employers. Of course, I'm a nurse, and I cannot help but being a nurse, and I cannot help by having my perceptions about the profession shaped by my own profession. But I wouldn't want you to get the impression that this talk and this topic are important because I am a nurse. As Neil has already said, and other reports have already put it out there, you know, governments and healthcare system leaders and private actors should expand funding and opportunities to increase the essential health workers on the front line of fighting resistance. And that's beautiful, that's great, that makes sense, doesn't it? So we need to expand the pool of workers. But on the other hand, I'm thinking, well, hang on a minute, by 2035, we're going to be 30 million healthcare workers. No matter how you define kind of formal healthcare worker, we're going to be short of that figure. So we already have got one of those sort of fundamental tensions. We need to increase the pool, but we already haven't got enough of what we've got. And it pains me, the idea of having sort of like a shortage of healthcare workers pains me, because, you know, I think about nurses, and again, whatever you call a nurse around the world, we are the largest healthcare workforce. And in that graph, you've got the ratio, the density of nurses to doctors. So the darker the map or the country, the more nurses per doctor, or the fewer doctors per nurse, if you want to put it that way. So, you know, probably it's not surprising to you that, you know, African countries have got many more nurses than doctors for very, very obvious reasons, very sad reasons. And just to put some figures in context, you know, in the UK, 150,000 doctors, nurses doubled that figure. In the US, just under 4 million registered nurses. India, 1.5 million nurses. I mean, the figures are staggering. And imagine if we could just add 1% of that healthcare workforce activated to be part of antimicrobial stewardship efforts. It feels powerful, doesn't it? It feels sort of important that nurses become part of these efforts. And 5 years ago already, we had claimed that there was a need for wider engagement. And you know, 5-6 years ago, we suggested that we had to move away a little bit from the traditional models of doctors and perhaps pharmacists and try to include nurses. And again, I'm kind of glad that what I call stewardship 2.0, the kind of next version of that document presented in 1997 in the US about what stewardship was. You know, stewardship 2.0 from Dilip Nathwani now talks about multidisciplinarity, and perhaps I could suggest interdisciplinarity and these interprofessional efforts. And although Dilip talks about specialist nurses, and I kind of may want to move away a little bit more and just think about nurses in general and all healthcare workers in general, but at least, you know, there is a more modern vision, or I like to think there's a bit more modern vision about our participation, isn't it? Now, unfortunately, because we are nurses, I think that we're not very good at sort of claiming stakes in that clinical practice, isn't it? And I think that still engagement of nurses has to be allowed and has to be encouraged, and particularly in the decision-making process, isn't it? And the more I think about antimicrobial stewardship, the less I think of it as a technical and clinical process, and more as a social, behavioral, conductual process, a decision-making process about using a particular resource called antimicrobials or antibiotics. I forgot to say about the acronyms. I'm still thinking about whether drug-resistant infections, DRIs, are the right term or not. But whenever I use one of those, I'll just mention. Anyway, so yeah, that engagement has to be allowed and encouraged, and that's fine. Some people have already said that nurses are part of this process. Nurses are doing stewardship. And when you read papers that are kind of written more or less by doctors with an add-on of a nurse as within the authorship, just talking about clinical roles and tasks, I get quite disappointed about those papers because I get quite enthused about saying, hang on a minute, someone else may have similar views to us. And of course, then they just focus on, the typical give antibiotics at the right time, don't miss doses, and take samples. And of course, they kind of talk about those nursing roles that probably you had in mind when you saw that this talk was going to be about nurses in stewardship, isn't it? Giving the right drug and taking samples, making sure that the right, or reminding doctors to prescribe the right drug for the right antibiotics, thinking about TDM, therapeutic drug monitoring, giving medication at the right time despite those 1 in 20 that don't get given or don't get given on time. But kind of those functions are very typical. I don't think that they are exciting, isn't it? Nursing road, right response, and so on. So that's fine. But I think that what is much more interesting is that other roles are starting to appear, other positions, other perspectives about how we could influence. And I'm particularly keen to think about that advocacy role. So, okay, so you use antimicrobials well, but how do you take part in that advocacy role, telling other people that they need to also be using them appropriately, taking part of their program? How about you connect with other healthcare workers? And I think that connection, that linking between teams and clinical teams and other healthcare workers, that knowledge brokering aspect, which I like to think of us nurses, think about, working across the healthcare economy, primary care, secondary care, long-term care, commissioning, working, of course, with doctors, pharmacists. We're very good nurses at that, I think. Or nurses are very good at that. And how, if you are able to influence that workforce, you may also be influencing this second-hand improved prescribing, as I also like to think about it. So that may be another perspective that hasn't been considered that much up until now. And again, it's interesting, just only a couple of years ago, the RC and the Royal College of Nursing presented some views about how we could improve antimicrobial stewardship. And that perspective, I liked it very much because it was sort of a very public health one, a very upper determinants of whatever happens to our patients and citizens and people. So, they were talking about, okay, yes, reducing the demand for antibiotics, but also influencing public and patient knowledge, okay, education, leading and implementing, although they were talking about immunizations, so not there yet, but a good progress, leading and implementing public health strategies. So you can see how the perspective has already shifted a little bit from the bedside to population, to the citizens, to the wider public health, isn't it? Some of the papers talk about, the role of nursing and antimicrobial stewardship, focusing on perhaps the policy aspect, the policy making, and of course from the US, you've got the executive, the higher level decision-making participation. And I think that we haven't really explored that perspective yet, have we? We haven't really thought about nurses as being influential in that remit or within that remit. It may be that we also kind of forget about this antimicrobial prescribing, and this is data from the Scottish NHS, and I have to say I look at whatever they do with admiration because in terms of participation of nurses in antimicrobial stewardship. And it was very interesting to see this report, and I haven't been able to find sort of the published data from this year, and that was from last year. But you can see that talks about nurse prescribing 8.4 of all antimicrobials in community were prescribed by nurses. And I was thinking, well, hang on a minute, if all these incentives and economic behavioral nudges that seem to be working very well for GPs suggest that GPs are going to be reducing prescribing, and then we've got an increasing number of prescriptions written by nurses. How are we going to be able to combine those two situations, isn't it? And again, some more data from the Scottish experience about nurses prescribing, telling us how the number of prescriptions written by nurses, these are nurse prescribers, non-medical prescribers, is increasing. Of course, we can argue about appropriateness, but I think that we have got that debate currently among medical prescribers, isn't it? You know, the appropriateness of of antimicrobial prescribers seems to be one of the hottest or hot topics nowadays. Again, whether you believe that antimicrobial stewardship has got anything to do with infection prevention and control, or whether you think that infection prevention and control is part of antimicrobial stewardship. It was very interesting to see this slide presented at ECMID just a couple of weeks ago at this big European conference of infectious diseases, and how for the first time someone had dared to suggest that infection prevention and control and antimicrobial stewardship could be fused within perhaps some patient safety, some quality agenda. And it was very interesting to see how, you know, that is IPC at the middle, infection prevention and control, doctors, nurses. I thought that patients should be at the center, perhaps citizens at the center. But it was the first time that someone had suggested or has suggested that the two of them go hand in hand. And we already have seen the importance of some prescribing in the reduction of C. diff, and how improving prescribing of antimicrobials may have better and more effect than what we can achieve with IPC programs, isn't it? But it's interesting, another shift in the paradigm about how we think of the participation of different healthcare workers. And in a paper that has just been accepted in the opening issue of the Journal of Antimicrobial Stewardship, we already propose some kind of wider thinking about the roles of doctors, nurses, and pharmacists, and many other healthcare workers. In there, we suggest that the integration between IPC, infection prevention, and antimicrobial stewardship in some settings also should include, water and sanitation, thinking about low and middle-income countries, and thinking about all the different aspects of health and social care that can be embedded, and what are the collaborative antimicrobial stewardship responsibilities. So I think it's interesting that we have got now possibilities to put out there these ideas of collaborative, interdisciplinary working, not led by a particular profession, but kind of equally shared. And I'm glad that we are at that point of the debate. But I was very lucky to be funded to go to Africa and learn from African nurses about what they do in general, but particularly what they're doing related to antimicrobial stewardship. And I'm thinking, is it time for nurses to do much more in AMS, about AMS, antimicrobial stewardship? And Euphrasi, the nurse there, she was exceptional. And not only she was running her own clinic, she was the owner of that health center. She was a manager. She was a business person, and her clinical experience was fantastic, but it was great to see works in any way. So I thought, hang on a minute, can we learn from what we have already seen published about TB, tuberculosis, and HIV care, the fantastic experiences that are telling us nurses can perhaps substitute other professionals achieving similar quality outcomes in terms of clinical care, and think about, can we apply that to the antimicrobial stewardship or antimicrobial use model? And again, I'm delighted to present some results from the Scottish team, not present, but be able to refer to some results from the Scottish team recently presented, isn't it? So the clinical impact, someone was already talking about, okay, what you are researching, what's the impact on the people, on our citizens, on the taxpayers, and it's fascinating to see already some of those results. And it's fair to say that, okay, when you think about the interventions that have been published, or the nurse-focused AMS interventions that have been published, they tend to be positive, isn't it? When we put an intervention out there that focuses on improving nurses' knowledge or participation in decision-making, we have got kind of better results before and after, and that's fine. And you've got a few papers where the education-focused interventions can increase the quality of antimicrobial use or can reduce the number of antimicrobials inappropriately used, and that's fine, that's great. But up until now, we've kind of just been talking about these clinical aspects, and I wonder whether you remember these public health framework. Because when I was first exposed to it, I thought that it was fantastic when I was studying public health. Because, of course, it explained why I wasn't able to stay on a good weight, or why I couldn't sort of not drink the recommended units, why all my health problems could be explained by these wider determinants. And I think that this framework is useful whether you are kind of like me, that think about the wider determinants, or whether you are the kind of people that want to make your country great again and think about all the problems that people experience are related to their own faults, isn't it? But I get worried when we have data presented like this. This is prescribing in the UK, and suggesting that most prescriptions may be prescribed in areas of low socioeconomic index, deprivation, and so on. And if you do believe that that data is really saying that, and you are happy with those results, thinking about nurses' participation in stewardship, I start to think about those 150 million citizens in the European Union that are classified, what's the label, as poor or socially deprived. And then I think about the amount of evidence that we have got out there already telling us about the socioeconomic determinants of antimicrobial use, socioeconomic determinants of infectious diseases, and the role of poverty in antimicrobial resistance. And I think that nurses have got an important role to play there, addressing these socioeconomic determinants, advocating for policies that don't actually exacerbate those determinants, but are able to reduce them. And it's all good and well to see the proper scientists and researchers presenting data about microbiome and bugs and drugs. That's fine, that's great. But thinking about the drivers of antimicrobial use, I wonder whether we perhaps need to focus a little bit more on those determinants. 4 barriers to resolve before we're able to implement participation of nurses in antimicrobial stewardship, and this is my point of view. The foundational barrier, what I call foundational, we still don't really know what has worked, we still don't really know why some of the interventions have worked in terms of implementing nurses' participation in stewardship. And unlike the traditional systematic reviews and RCTs, where we have got an intervention that leads to a result or not, and we're happy with that linear relation, I think that, interventions we know are much more complex, and particularly when they involve humans, and humans are funny and complex and unpredictable, that's my perspective. So we have conducted a realist review of the evidence out there. And realist reviews are kind of reviews that really want to understand what has worked for whom and why. So they're kind of peculiar, but I like them because they allow us to understand that. So then we can scale up interventions that may have worked in a setting and moving. So if you wanted to carry out one of those reviews, you have to actually come up with a priori theory, so why the intervention may have been successful, and then you use the evidence out there to try to understand the context, the mechanism, the outcomes, and I really encourage you to of course, read the evidence when we publish. And the beautiful element of these reviews is that you are able to use your theories, so match your theories with real-life evidence. So I'm working with colleagues in Kyoto, Scotland, Brazil, South Africa, Rwanda, to say, hang on a minute, show me what's working in your settings, and let's match that with the theory that we've come up from the published evidence, okay? One of the other barriers that I think we need to resolve is the barrier of ownership and branding. So if you were to ask any of the nurses or any nurse around the world, do you think that you do antimicrobial stewardship? The majority of them will say, I don't know what you're on about. I don't do that. It's not part of my job. But when you ask people, would you be willing to participate in any of these interventions that seem to be included or are included in Start, Smart, Then Focus, and kind of policies, guidelines, plans of best practice, you start to think about, hang on a minute, many of these tasks or components are part of what nurses do on a daily basis, isn't it? Timing of antimicrobials, IPC, MCNS, biological samples, TDM, intravenous use. So I think that if we say to people, do you do AMS, they'll say no. But if you say to people, how many of these you do, they'll say, well, many of them, if not all. In terms of education, again, if you ask nurses, what you should do in terms of AMS, the majority of them will not know. And we have published already results when we contacted all universities in the UK offering veterinary medicine, dentistry, pharmacy, nursing, medicine courses, asking them specifically, what do you teach within your courses? And you can see that the nursing content related to antimicrobial stewardship was much lower compared with all the other professions. And we targeted all these professions, of course, because they are involved in the use of antimicrobials, because it's not just prescribing clearly, it's the influencing of those decisions. So you can see how we've got that educational handicap. And it may be as well that what you call nurses or we call nurses and what we think about antimicrobial knowledge is constantly changing as well, isn't it? On the left, you've got the proposals from the nursing regulatory body suggesting that within a couple of years, any nurse will be able to prescribe within a limited formulary. And what is that going to imply for clinical practice and the care of our patients? And of course, we have got new figures. What is a nursing associate? Next month, you'll have one on your hospital. How are they going to learn? What are they going to learn about related to antimicrobials and antimicrobial use? It may be that interventions such as mHealth can help to increase your knowledge about AMS. And we already have got nice experiences published about our own experience moving away from the printed policy to an app. And I think that mHealth and apps may have a role. And again, you can see how apps specifically focus on nurses' participation in that process have been developed. And we have developed a prescribing game that you can download and use, where not only we're focusing on allowing you to learn from the typical diagnosing, the clinical management of infections, and what antibiotics you would use. And those are some of the gamification elements. And